Good evening, everyone, and welcome to our online international speaker series session 4 on ESR1 monitoring in HR+HER2 breast cancers. And this virtual webinar is supported by AstraZeneca. So first and foremost, I would like to extend a warm welcome to our international speaker, Dr. Shaina Daud, ma'am. Welcome, ma'am.
Thank you.
To our esteemed faculty members who have graciously agreed to share their expertise with us today. Welcome to all the faculty members. To all our delegates who have registered for this webinar, I would like to express my heartfelt gratitude. So without further ado, let us move on to our first session. Before that, let me mention that you can ask your questions while the session is ongoing, and you can see a tab on the left-hand side with Ask Question mentioned over there. You can put your doubts or queries during the session, and the speaker will address your questions after the session will get end. So now, with this, it is my pleasure to introduce our first speaker, Dr. Shaina Daud, ma'am. She's consultant in medical oncologist and professor in Mediclinic City Hospital, Dubai. And she's going to deliver the talk on ESR1, the word of power in HR+HER2 breast cancers. Thank you, and over to you, ma'am.
So thank you very much, and thank you for the invitation. It's truly been a whirlwind ride here on the International Speaker Tour, but I'm very, very happy to be here and actually talking to you about ESR1 mutations in patients with metastatic breast cancer. So as you all know, there's been some exciting data in the management of patients with hormone receptor positive HER2 negative metastatic breast cancer in the last decade. I think probably the most exciting has been the fact that we have changed the way that we treat our patients in the first line setting with the introduction of CDK4/6 inhibitors, where we know CDK4/6 inhibitors not only improves progression-free survival, but also overall survival in our patients. And you can see the overall survival is now more than 60 months in these patients. Unfortunately, ultimately, endocrine resistance actually develops. And you can see that the drivers of endocrine resistance can either be ER dependent or ER independent. And we know that in an ER dependent situation, the estrogen receptor remains a viable therapeutic target in these tumors with ESR1 mutation mediated ligand independent ER signaling, and it promotes endocrine resistance by constitutive ER activity. It upregulates the activator binding, and it promotes stability against proteolytic degradation. Then you have those patients that have ER independent resistance. And this is really mediated by mutations or amplifications in that RTK MAP kinase pathway, as well as in the PI3 kinase pathway. Now let's focus our efforts today in terms of looking at that ESR1 mutation. Now, this slide shows you the distribution of the annotated substitutions in that ESR1 gene, and you can see the most prevalent mutations are actually located in the ligand binding domain, with 90% of the characterized mutations with endocrine resistance being Y537, the D538, and the E380. And there are 13 identified mutations for variants of these different variants of E380Q, 44 for Y537, as well as 46 for the D538. So again, it's a very vast plethora of different mutations that you can get with that ESR1 mutation. Now, this slide just sort of looks at the mechanisms of resistance with that ESR1 mutation. You've got in patients who've got an ESR wild type disease, you see there's aromatase inhibitor depletion of estrogen inhibits ESR1 activity, and SERMs such as tamoxifen, it alters the ESR1 binding partners and transactivation ability, and SERDs such as fulvestrant, it actually inhibits ESR1 activity and proteolytic stability. However, if you have an ESR1 mutation, aromatase inhibitors are actually ineffective, since ESR1 mutation does not require actually estrogen, and tamoxifen, drugs such as tamoxifen and fulvestrant, they bind less strongly to an ESR1 mutation. So just looking at the many routes of endocrine resistance that a patient can get, from being endocrine sensitive to all the way to being endocrine resistant, you can see it goes through multiple pathways, as I described earlier on. The question is, could evolutionary tracks actually influence choice of subsequent therapies? And as I've just mentioned, if you give a patient that's got an alteration in that MAP kinase pathway or is ESR1 mutant, you can see that AI therapy or aromatase therapy, aromatase inhibitor therapy doesn't work that well. It actually works in patients who don't have those alterations. While if you give SERD therapy, it actually works across the spectrum of different variables in terms of developing endocrine resistance. And we've seen this in clinical data. And you can see the combined analysis of phase 3 data from the SOPHIA trial and the EFFECT trial that looked at using fulvestrant. You can see that if you have an ESR wild type disease, whether you're treating with a aromatase inhibitor or not, it works, and it works very well. But if you have an ESR mutant patient, and this is the Kaplan-Meier curve over here, giving a drug such as an aromasin inhibitor doesn't give you that much of a progression-free survival. But the minute you give fulvestrant in that patient who's ESR mutant, it's like treating an ESR wild type patient. And you can see that even the overall survival of patients who've got an ESR wild type disease is very different from those who've got an ESR mutant disease, telling us it's associated with a worse prognostic outcome. Now, we've got different endocrine therapies that may address the issue of endocrine resistance in metastatic breast cancer, such as SERDs, which have different key advantages such as, one, it's an oral formulation. So you have oral SERDs having an oral formulation, such as, compared to fulvestrant, which requires a patient to actually have intramuscular administration. It has a higher potency. It has activity in ESR1 mutant metastatic breast cancer, and has been shown that it works also in patients post CDK4/6 progression. Now, there have been a number of different studies looking at monotherapy use of oral SERDs. The two that we'll be concentrating on initially is the Emerald study and the Serena-2. Emerald looked at elacestrant, while Serena-2 looked at camizestrant. And I want to call to your attention that in Emerald, 100% of patients had actually progressed on a CDK4/6 inhibitor, while only 50% in Serena-2 had progressed on a CDK4/6 inhibitor. You can see that these patients were not first or second line, but really heavily pretreated. And you can see about 40% of these patients actually had an ESR1 mutation. Just showing you the trial schema over here, the Emerald study took patients, again, who'd had 1 to 2 lines of prior therapy, all had progressed on a CDK4/6 inhibitor, prior chemotherapy was allowed, and these patients were randomized to get either elacestrant or investigated choice of endocrine therapy, with a primary endpoint of progression-free survival. The Serena-2, again, a heavily pretreated group of patients. About 50% of them had received prior CDK4/6, and these patients in a phase 2 setting, while Emerald was a phase 3 trial, Serena-2 was a phase 2 trial, which randomized these patients to get either camizestrant at 3 different doses or fulvestrant as the comparator arm, and you can see the primary endpoint was progression-free survival. Now, the question then was, compared to physician choice of endocrine therapy, in a patient who's got endocrine-resistant disease, does monotherapy with an oral SERD actually work? And if you look at the whole cohort of patients, you can actually see that an oral SERD, either in the form of elacestrant in the Emerald trial or in the Serena-2 with the use of camizestrant, was better than using physician choice of endocrine therapy, mainly that was fulvestrant. The second question that came was, how do oral SERDs actually perform in that ESR1 mutation cohort? And you can see that it performs better in that ESR1 mutation cohort. You can see in the Emerald study, in patients who had an ESR1 mutation, when you gave elacestrant, it improved the progression-free survival from 1.9 months to 3.8 months, translating into a hazard ratio of 0.65. In the Serena-2 trial, you can see that it improved the progression-free survival from 2 months to 9.2 months in that ESR1 mutation cohort. Now, the Serena-2 trial also asked another very interesting question, at least for me, was, does the number of ESR1 mutation actually impact the efficacy associated with an oral SERD, in this case, camizestrant? And right off the bat, this is a very busy slide, but what you can take away from this slide is that the greatest median progression-free survival improvement was actually seen in those patients who had a single ESR1 mutation versus those who had multiple ESR1 mutations, actually telling us that the earlier you intervene before the development of additional ESR1 mutations, that's the best time to actually intervene with an oral SERD. When you went back to the Emerald study, since 100% of these patients had received prior CDK4/6 inhibitor, they actually asked the very important question: did the prior duration of CDK4/6 inhibitor actually influence the outcome of patients? And what you essentially see is that the longer you stayed on a CDK4/6 inhibitor, the better the benefit with elacestrant. You can see the biggest benefit was in those patients who had more than 12 to 18 months of prior CDK4/6 inhibitor, where you were seeing a progression-free survival improvement of almost 6 months. Now, when you go back to the oral SERD monotherapy bit, what you see from these Kaplan-Meier curves across the board is that there is this very rapid initial drop in the Kaplan-Meier curves, where you can see the Kaplan-Meier curve is actually practically sitting on top of each other, but a very rapid drop, identifying a group of patients who are refractory to single-agent endocrine therapy, either fulvestrant or oral SERD. But then later on, you see a nice separation in the Kaplan-Meier curves, suggesting that these are the groups of patients who've still got endocrine-sensitive disease. The question that comes is, can we avoid this drop with combination endocrine therapy? Can we identify the more endocrine resistant patients who need that combination endocrine therapy. So where do we stand with oral SERDs? And I think with just the data that I've shown you, what I can conclude is that oral SERDs appear to work better than fulvestrant or an aromatase inhibitor in an ESR1 mutation selected endocrine resistant cohort. We know that the improvement in efficacy appears modest at best when you use a monotherapy with ER positivity and ESR1 mutation, not being perfect biomarkers for cohort selection. The question then comes is how will oral SERDs perform after other targeted therapies? Say, suppose you use it after using a target for PIK3CA mutation positive breast cancer. And also, although I'm not going to talk about it, toxicity associated with oral SERDs is also not negligible. So then the question comes, should we be looking at taking oral SERDs into the earlier line setting? Remember, the Parsifal trial actually looked at taking fulvestrant plus a CDK4/6 inhibitor in the first-line endocrine-sensitive setting, comparing it to an aromatase inhibitor plus endocrine plus CDK4/6 inhibitor, and you see that there's absolutely no difference. Would we have seen something different, say, with an oral SERD? And should we be looking at combining oral SERDs with other agents? So that set the stage for AMBER-3. AMBER-3, a very interesting study, was presented a couple of years ago, actually, at San Antonio. Very interesting trial that looked at another oral SERD in the form of imlunestrant. These were patients hormone receptor positive, HER2 negative, metastatic breast cancer. They had to have certain criteria, so they could either have recurred on or within 12 months of completing their adjuvant endocrine therapy. In the advanced breast cancer setting, they needed to have at least progressed on one line of endocrine therapy with or without a CDK4/6 inhibitor and no other therapy. So again, these patients had not received prior chemotherapy, slightly different from what we saw with Emerald and Serena-2. These patients either were randomized to arm A, where they got imlunestrant single agent, or standard of care endocrine therapy in arm B, or a combination of imlunestrant plus abemaciclib. The primary endpoint was progression-free survival, looking at arm A compared to arm B or arm A compared to arm C. Now, when you're looking at the progression-free survival across the bat, irrespective of the ESR1 mutation, when you looked at imlunestrant versus standard of care endocrine therapy, you can see an improvement in progression-free survival from 3.8 months to 5.5 months. Then when you're looking at, this was for the patients with ESR1 mutation. When you're looking at patients comparing arm A to arm B in those irrespective of the ESR1 mutation, you can see there's practically no difference in the Kaplan-Meier curve. The progression-free survival in standard of care endocrine therapy, 5.5 months, imlunestrant, 5.6 months. So really telling us that it's working mainly in those patients with an ESR1 mutation. Then you're looking at arm C versus arm A, where you're seeing the combination of imlunestrant plus abemaciclib compared to imlunestrant alone. And you can see that there's a nice separation of the Kaplan-Meier curves, progression-free survival actually improving from 5.5 months to 9.4 months. Now let's go back to the monotherapy. Remember I said right at the very beginning, you're seeing that rapid drop in the Kaplan-Meier curves. You're seeing it in Emerald with elacestrant. You're seeing it with Serena-2, with camizestrant, and now with AMBER-3, again, you're seeing that rapid drop with imlunestrant, telling us that single-agent monotherapy oral SERD, across the types of oral SERDs that you're using, you're seeing that group of patients that are just not responding irrespective. Perhaps a combination of imlunestrant plus abemaciclib might overcome that. And when you look at AMBER-3 in those patients post-CDK4/6 progression, or in those patients who've got an ESR1 mutation cohort, you'll see that that drop is not as sharp. So can we avoid this drop with combination endocrine therapy? Partially, yes. Can we identify the more endocrine resistant patients who need that combination? Unfortunately, we can't right now, and we have to await the translational component of AMBER-3. At ESMO Breast this year, we did see some subgroup analysis that I thought was very interesting when they looked at the combination of imlunestrant plus abema versus imlunestrant alone in those patients who were CDK4/6 pre-treated, who had an ESR1 mutation, a nice separation of the Kaplan-Meier curves. In those without an ESR1 mutation, again, it works, the combination, even in those patients without an ESR1 mutation. In patients with a PIK3CA mutation or without a PIK3CA mutation who had been CDK4/6 inhibitor pretreated, again, the combination of imlunestrant plus abema outdid the use of single agent imlunestrant. And in those patients with a co-mutation, which I think that we are going to start to identify in our patients as we're testing them more and more, you can see those patients who were pre-treated with CDK4/6 inhibitor, who had a combination of ESR1 mutation plus a PIK3CA mutation, you can see the PFS improved from 3.8 months to 12.9 months with the combination of imlunestrant plus abemaciclib. And remember, these were CDK4/6 inhibitor pre-treated patients. So what does AMBER-3 actually tell you? Imlunestrant works in the ESR1 mutation cohort. The combination with abemaciclib works in all cohorts, irrespective of the presence of a biomarker, and partially overcomes the true endocrine-resistant tumors that will not respond to single-agent endocrine therapy. The combo works even in the presence of a co-mutation. I just showed you that. And AMBER-3 gives further evidence that you can actually use a CDK4/6 inhibitor beyond progression of disease. But I think there's still more questions to come. Perhaps intervening early with a switch in therapy as ESR1 mutation emerges might be the correct strategy. So that set the platform for the PADA-1 study. The PADA-1 study was a study that actually came out way back in 2020 when COVID actually had just hit. And this was a very interesting study that took patients first-line endocrine sensitive, metastatic breast cancer, hormone receptor positive, HER2 negative, who were all treated with an aromatase inhibitor plus palbociclib, and they were treated at various time points to see if there was an ESR1 mutation. As they saw a rising ESR1 mutation VAF, they were then randomized at that point in the absence of radiological progression. So these were patients who had molecular progression of disease, randomized to either continue an AI plus palbociclib or then receive fulvestrant plus palbociclib. Now, an interesting point about this study was at baseline. Now, we know ESR1 mutations are acquired mutation. At baseline, 33 patients that constituted 3.2% of the cohort actually had an ESR1 mutation. And if you see that those patients at baseline who had an ESR1 mutation, PFS was better in those who did not have an ESR1 mutation versus those who did have an ESR1 mutation. Now, interestingly, in this particular study, they also asked what happened to that ESR1 mutation under the pressure of an aromatase inhibitor plus palbociclib. And what they essentially showed was that when you gave CDK4/6 plus aromatase inhibitor, about 23 of the 33 patients actually cleared their ESR1 mutation, and then it emerged again later on. So if you're worried about actually treating a patient at baseline who has an ESR1 mutation and are endocrine sensitive, you can actually give a CDK4/6 plus an AI. And this set the standard of what we will see later on in SERENA-6 of why they chose that 6-month mark before they actually started testing patients for ESR1 mutation. Now, the PADA-1, remember the progression-free survival was the primary endpoint, and you can see that actually switching to an fulvestrant plus palbociclib improved the progression-free survival from 5.8 months to 12.8 months in these patients who had that rising ESR1 mutation. Now, interestingly, there was an optional crossover for patients who progressed on that AI plus a CDK4/6. About 49 patients were allowed to cross over, and you can see that their median progression-free survival was 3.5 months. And if you added that to the 5.8 months that you're getting with an AI plus palbociclib in this arm, the combined was still shorter than the almost 12 months improvement that you are seeing with actually that switch strategy. And you can see that that PFS2 was also improved from 14 months to 29.4 months. Now, PADA-1 set the stage for SERENA-6. SERENA-6 was presented as an ASCO plenary this year at ASCO. Phase 3 randomized clinical trial took patients ER positive, HER2 negative, metastatic breast cancer. All these patients had actually received an AI plus a CDK4/6 inhibitor as initial endocrine therapy, and they had to be on it for at least 6 months. So even if you had an ESR1 mutation at baseline, remember I showed you in PADA-1, it would probably clear it. So for at least 6 months, and then at molecular progression, because these patients were tested at various time points for an ESR1 mutation, and the presence of an ESR1 mutation was the indicated that there was now molecular progression. They could not have radiological progression. They were randomized to get either camizestrant plus continuing the same CDK4/6 inhibitor, or randomized to continue the same AI plus the CDK4/6 inhibitor. The primary endpoint of this trial was progression-free survival. You can see 76% of patients received palbociclib, and 62% of these patients had received a prior CDK4/6 inhibitor for more than 18 months. And unfortunately, and I think this is the biggest flaw of the trial, that at radiological progression, crossover was not allowed. Now, this is the way that they did ESR1 mutation surveillance, and you can see that it's in the fine print over here. You can see that they actually had estimated that 3,325 patients would be screened. Only 548 patients ultimately were enrolled because they wanted a certain number of patients. But one of the biggest things was that they selected a good group of patients, right? So most of these patients had to have an AI plus a CDK4/6 inhibitor for more than 6 months. We know that the average time that these patients actually stayed on it was more than 18 months. So for me, when I'm thinking about the study, the patients who were recurring early were actually removed from this trial. So you have to think about it. They were selecting a better group of patients. You can see a large number of patients had to be screened to reach a small number of patients randomized. But again, look at the fine print. 3,256 patients, if 40% of them had an ESR1 mutation, that would equate to 1,302 patients that should have been randomized. However, only 548 patients were randomized because that was their cutoff of the number of patients that could be included. 51% of patients had a positive ESR1 mutation on their first test, 38% after 2 to 5 tests, and 11% at more than 5 tests. You can see that the probability of a positive test actually decreases with time. Looking at that primary endpoint, that was a spectacular result in my mind. You can see that it improved the progression-free survival from 9.2 months to 16 months, resulting in an improvement of 6.8 months. And you can see that the PFS2, again, a very nice separation of the Kaplan-Meier curves, favoring the group of patients who are getting camizestrant plus CDK4/6 inhibitor, but again, calling to your attention, at radiological progression, crossover was not allowed. So these are the questions I asked myself post SERENA-6. Is this a well-designed trial that asked a specific question? And my simple answer is yes. It told us that camizestrant works. It works very well when an ESR1 mutation is detected at molecular progression of disease. But how long do you test for an ESR1 mutation? Should you be doing it forever? Well, we know that the prevalence of an ESR1 mutation in untreated versus treated is very, very unique to this cohort of patients. You can see, and in an untreated cohort of patients, first-line treatment is about 5%. Second line, it becomes 33%. In third-line patients, up to 40%. So it's an acquired mutation over time. At ESMO Breast this year, the investigators of PADA actually went back and looked at the incidence of ESR1 mutation over time. And you can see essentially it's a bell curve. The cumulative incidence starts rising at 6 months, and you see fewer mutations detected pre-6 months and after 30 months. So should this be the cohort of patients that we should be testing between 6 and 30 months? You also see ESR1 mutation risks are higher in younger patients and patients with bone metastases. So is that a sort of a cohort of patients that we need to be looking at? And then when you go back to SERENA-6, and you look at the incidence of ESR1 mutation over time. You can see at first test, at subsequent test, but look at the median range. It's about 22 months in each arm of the study. So again, telling us the median time is 22 months. So is there an optimal time point or time period that we need to be restricting that ESR1 testing? Then the next question is the PFS2 endpoint used in SERENA-6 a valid surrogate for overall survival? Remember, I told you crossover was not allowed. But the way I look at it, you need to look at AMBER-3 and you need to look at SERENA-6, the primary endpoints in terms of progression-free survival. When you're looking at AMBER-3, you can still see that drop in the Kaplan-Meier curves, although partially overcome by using combination, but you don't see that drop in SERENA-6. So this tells me that you need to look at it a little bit differently. Now, when I go back, I did a thought experiment. I actually looked at the progression-free survival on camizestrant plus CDK4/6. The PFS is about 16 months. When you look at SERENA-6, the AI and CDK4/6 inhibitor from molecular progression to radiological progression, you can see it's 9.2 months. Remember, AMBER-3 was post-progression. You had that data for CDK4/6. You can see it's 11.1 months. If I hypothetically had used imlunestrant plus abema, 11.1 months post AI plus CDK4/6. So the total PFS is about 20.3 months, actually beating the 16 months that we see with SERENA-6. So why should I use SERENA-6 then? So the next question comes, does intervention at molecular progression allow you to identify patients who have not developed an ER independence? Again, I'm going to go back to AMBER-3 and SERENA-6. You don't see this drop in that Kaplan-Meier curve. So can we avoid this drop with combination endocrine therapy if you used an oral SERD combination endocrine therapy at the time of molecular progression? And the simple answer is yes, you are in fact overcoming that drop by that switch, because we know that patients, and this comes from AMBER-3 actually, when you look at that Kaplan-Meier curves, you have that drop. The rapid progresses with this complete ER independence. And for me, switching therapy at molecular progression reduces the probability of treating a patient with complete ER independence. Then what is the best strategy when you have a co-mutation? And I've just put this thought experiment again in my head because we'll never be able to answer this question. In your first case, think of a 36-year-old lady with stage 4 de novo breast cancer, hormone receptor positive, HER2 negative, treated with CDK4/6 plus an AI plus ovarian function suppression. You do SERENA-6 and do surveillance. You see a VAF that's rising for a baseline PIK3CA mutation. Will you not intervene in that patient? In a 60-year-old lady with recurrent breast cancer, hormone receptor positive, HER2 negative, treated with CDK4/6 plus an AI, 6 months post-diagnosis, has an ESR1 mutation and a PIK3CA mutation, which one will you target? Currently, we have no evidence to guide us. Finally, will a PROTAC inhibitor be better for patients with an ESR1 mutation? And I had to show this data because it was presented at ASCO. PROTAC inhibitor in the form of vepdegestrant, I can't pronounce this drug, was presented in the VERITAC-2 trial that took patients post-CDK4/6, randomized to get this PROTAC inhibitor versus fulvestrant. Primary endpoint was progression-free survival, and you can see not much of a difference between the two cohorts, but you do see that difference in the ESR1 mutation cohort, where you're seeing an improvement from 2.1 months to 5 months, similar to what we saw in AMBER-3, but still you're seeing that drop in the Kaplan-Meier curves. So will PROTAC inhibitors be better for patients with an ESR1 mutation? My answer is no for the time being. So what is the best method then to test for an ESR1 mutation? Well, we do have patients that were studied in the plasma match study from Nick Turner's group. This was an open label, multi-center, multi-cohort trial in which they took patients with metastatic breast cancer, heavily pretreated, who were tested with liquid biopsy to see if they had an ESR1 mutation, a HER2 mutation, AKT mutation, and they were treated with various agents, including fulvestrant and capivasertib in the PIK3CA or AKT1 mutation cohort, and neratinib in the HER2 mutation. And you can see that when you're detecting these biomarkers with liquid biopsy, you're actually getting very nice overall responses when you're treating them with biomarker-directed therapy. However, this particular study also looked at the agreement between digital PCR ctDNA testing and advanced disease tissue sequencing in a subgroup of these patients. And what essentially you saw was that in those patients with ESR1 mutation, the best method to actually detect ESR1 was with liquid biopsy rather than with tissue, because the concordance was not that good in patients who were with tissue tested. So you could get more positive ESR1 mutations with liquid versus with tissue. There's some real world data that has also demonstrated the prevalence of ESR1 mutation actually increases with lines of therapy, and you see the difference between tissue and liquid in that with liquid, you're seeing higher percentages of patients that you're actually detecting ESR1. So using a liquid biopsy with the ESR1 mutation allows for capture of heterogeneity, allows for testing at multiple time points, and has a higher sensitivity for ESR1 mutation. And the ASCO guidelines also recommend that you use a liquid-based biopsy platform for ESR1 mutation. But if you can't do it, if you've got a negative test and you're sure that patient has an ESR1 mutation, do a biopsy and use that to test for ESR1 mutation. In the era of adjuvant, so do we need to wait for further follow-up before implementation of SERENA-6? Maybe. In the era of adjuvant CDK4/6 inhibitor, how would SERENA-6 as strategy actually fit? I'm hoping Shona is going to address that question in her panel discussion. And will I use it in the clinic if approved? I will, but for a select group of patients. And just to let you know that SERENA-6 is actually approved in the United Arab Emirates in June 2025, and we're actually hoping to start treating our patients with it in September. So in my last two slides, where do I see AMBER and where do I see SERENA-6? This is in the recurrent setting. In the recurrent setting, obviously, you have to see if your patients have actually completed endocrine therapy more than 12 months or less than 12 months. If they completed more than 12 months, we usually see if we can either give them CDK4/6 inhibitor or not, depending on whether they have received in the adjuvant setting. If they've less than 12 months, again, we can see if we can re-challenge them with a CDK4/6 inhibitor. Upon progression, we profile our tumors and treat accordingly. I think AMBER-3 will probably be in these two categories over here, but I think this is where I see SERENA-6 in those patients at progression of disease. And then, of course, when you're re-challenging, perhaps we need to think about SERENA-6 there. In patients who have got stage 4 de novo disease, you give them CDK4/6, and then at progression of disease, again, you can do your molecular profiling and you have AMBER-3 that you could use. But I think this is where we're going to start thinking about SERENA-6. So thank you very much.
Thanks, Shaina. As usual, teasing out the data is your strength, and you teased it out amazingly. I think you love mathematical figures. So, adding the PFS of 2 and 3 and getting them to show what needs to be shown, that's great. That's wonderful. So I think if the organizers agree, hi, Chirag, how are you? So we can start off with the panel if I'm allowed to. Yeah.
Ma'am, sure, ma'am. Will you take then all the questions during the panel discussion itself?
There are only 2 questions I can see in the box right now. So if any more come, you can keep telling me. Is that okay?
Sure,
Yeah?
ma'am. We can.
Okay.
No problem. Let's do that, Priyanshi.
So we'll begin with the panel discussion. So thank you so much, ma'am, for the wonderful session. With this, let us move on to our second session, which is a panel discussion on leveraging the power of liquid biopsy.
So thank you, everyone. and I'm really happy to be here to moderate this. It was a little last minute, but we will try and answer a lot of questions that need to be done. We have a nice mix of clinical oncologists and molecular personnel and molecular scientists. So we'll get a lot of information from the lab as well as how to measure and quantify and which ESR1 mutations are really important for us. So though Shaina set the stage very nicely, I thought I'd just reactivate your memory. So when we look at the estrogen receptor domains, we know there's an N-terminus, a C-terminus, and activating function 1 and 2. The DNA binding domain is the domain by which the receptor actually binds to the EREs on our DNA. The hinge connects the binding domain with the ligand binding domain, which is very, very important, where all your ESR1 activating mutations that we talked about reside. And this is the spot where estradiol, SERMs, SERDs, as well as the co-regulators bind. It also forms a helix 12, which actually determines the stability, as we talked about, of the estrogen receptor. So we have 3 classes of drugs which have been approved. These are their mechanisms of resistance. So with SERMs, it's agonistic activity.
Ma'am, sorry to interrupt you. Your presentation is not visible. Should I share your presentation on behalf of you?
Yes, please.
Just a second, ma'am.
So ma'am, can I introduce the panelist?
Yes, please.
Yes. So I would like to welcome our panelists. First, Dr. Shaina Daud ma'am. Then Dr. Anbarsan Shekhar, he's Associate Professor from ATRAC Tata Memorial Center. Dr. Chirag Desai, Consultant Medical Oncologist and Founder Director in Hematology Clinic at Vedanta Institute of Medical Sciences. Dr. Suruchi Agarwal, she's Associate Director Diagnostics from Strand Life Sciences and Consultant Genomic Scientist. Dr. Moshmi, she's Associate Professor, Senior Consultant and Head in Molecular Biology and Cytogenetics from Amrita Hospital. Dr. Rekha Pai, Professor, Molecular Pathology Lab from Christian Medical College and Hospital. Dr. Tripti Pai, she's Professor in Department of Pathology from Tata Memorial Hospital, Mumbai. And Dr. Shona Nag ma'am will moderate the session. She's the Director Oncology from Sayadri Multi-Speciality Hospital, Pune. She's one of the best cancer specialists in Pune. So thank you, ma'am, and over to you. You can start the session.
Thank you so much. So sorry about that. If my slides can be put up, that would be great. Okay.
Yes, ma'am. I have put up your slide. I'm putting on the second.
Yes. So we were talking about the estrogen receptor. We were talking about the ligand binding domain. And then we talked about the current approved endocrine therapies, their mechanisms of resistance. With SERMs, its agonistic activity. With AIs, its ligand-independent activity in a crosstalk with other pathways. And finally, the SERDs, which are the hot topic for today. With fulvestrant, the main problem has been poor bioavailability and pharmacokinetics, which we hope to overcome with the newer drugs. Next slide, please. So when we talk about missense mutations, and this was one of the questions in the chat box, that what are the implications really for adjuvant therapy in ER-positive disease? So just to note, it's these mutations which arise under selective pressure of endocrine treatment in the metastatic setting. So the patient will have had to be treated with AIs in the metastatic setting to give rise to ESR1 mutations. And as time goes by, Shaina showed 6 months, basically, they start to develop these mutations and multiply them. So when you look at the prevalence, it's not really in a primary, it happens after endocrine therapy in metastatic disease. Next slide, please. So there are different allelic mutations as mentioned, and it was the Y537S, which is has very strong ligand independent activity and resistance to ER as well. And then, of course, the structure and the level of activity actually goes down as you go down these mutations. Please keep clicking. So this has clinical implications, as we saw in Sophia and Effect. Click once more, please. And data from really the Paloma 3 study showed that patients who were treated, including the fulvestrant alone arm with an ESR1 mutation, had decreased PFS with fulvestrant. So this is pretty clear that there is resistance to fulvestrant as well. Next slide, please. And if you look at the development of SERDs, there is a concept called functional allostery, which is important because the conformation of the receptor is influenced by the structure of the ligand with which it binds, and that shape kind of predicts how active this combination is going to be. And as you know, it explains the pharmacology of the various SERMs. And if you look at the landscape of the SERMs and SERDs in breast cancer, you can see that as the SERM activity reduces, the SERD activity becomes more prominent. And somewhere in the middle are these newer SERDs that we found, the camizestrant, giredestrant, imlunestrant, etc. And they also, elacestrant is not a very, very strong SERD. And as you go advanced, you can get higher CNS penetration with these SERDs as well. Next slide. So let's start with the first question, and I'll address this to Shaina. At what point in an ER-positive metastatic breast cancer, you covered this already, but just for the people who are listening in and who've joined late, would it be reasonable to start checking for ESR1 and PIK3 mutations?
So we know that everyone in the first line setting should be getting a CDK4/6 inhibitor. So at the time of diagnosis, if they haven't received one, they don't necessarily have to be tested for either ESR1 or a PIK3CA because it's not going to influence the type of therapy that you're going to give. But the problem is our entire algorithm has changed a little bit since the introduction of adjuvant CDK4/6 inhibitor.
Yes.
So I have to admit that now my recurrent cases, all of them at baseline, I'll profile the tumor and I'll automatically get that information on ESR1 and PIK3CA. So I think it's important to have that information at hand. How you will use it will really depend on what that patient has received before.
So any of my panelists wish to comment? Chirag, would you like to add something? Dr. Anbarsan, would you like to say something?
Yeah, sure. So, Shona, we will always want to have this information at the baseline because one of the indication for changing the treatment in the trial like Serena 6 is increase in the level of mutation, increase in the wave of mutation, and we can know the increase only if we had the information on the baseline.
Correct.
So we will do the mutation at baseline and then we will do it periodically. So I will not start doing it periodically in my practice so far, but I will look at the maturing trial with the survival information before I change my practice. I mean, that question will, of course, will come further in your panel.
But tell me, if you were to do it at baseline, right, at the recurrence or whatever, at the very first instance, and you pick up a PIK3 mutation, would you change your strategy if inavolisib was available and try and do a triplet therapy instead of a doublet therapy? I mean,
so inavolisib, if available, I will be using triplet therapy. But if not, I will use the CDK4/6 and I will not use PIK3 directed therapy in the first line.
Shaina, is inavolisib available where you practice?
Yes, it is available, but I'd like to, point out a few things. So, inavolisib, the triplet therapy from the INAVO study, is a very, 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 very specific group of patients who are recurring on endocrine therapy and have a PIK3CA mutation. And the 99.9% of these patients never received a CDK4/6 inhibitor in the adjuvant setting. So how it's going to work in our group of patients nowadays is going to be very interesting to see. So that's number one. Number two, there is a difference between the way ESR was tested in PADA and Serena-6. So in PADA, they, from the day that the patient was diagnosed, they gave them an AI CDK4/6. They tested for ESR1 mutation. We had a 3.5% group of patients that had a baseline ESR1, but they didn't randomize them at that point. You had to see an increasing VAF. That was the basis. But Serena-6 wasn't like that. Serena-6 did not look at the rising VAF unless we see the translational component of the trial. I don't have the data for that, and I wonder if the AstraZeneca people would like to pitch in and just correct me. But as far as I know, it was a binary thing. You either detect it or you don't detect it. You don't look for the rising VAF. So it doesn't matter whether the patient had it at baseline or not. And I think the way that the Serena-6 trial was designed was based on the information that they got on PADA. Because they saw that irrespective of whether you had an ESR1 mutation at baseline, AI plus CDK4/6 actually cleared it. And then it was a reemergence. There was a reemergence later on, and it worked in those patients. So you can't deny them, that
A
AI plus
CDK4/6 inhibitor. Absolutely.
Exactly. So that is why they had
Absolutely.
that 6 months. Plus, you have the higher incidence of doing an ESR1, of getting an ESR1 mutation post 6 months of an AI. So I think it's reasonable to test it at baseline. The question that comes up is, if you detected it at baseline, are you going to do
What you're going to
Serena-6 or
do?
not?
Yes.
I think there's a lot of confusion over there,
Yes,
because our
there is.
patients are now getting 5 years of AI plus 2 or 3 years of CDK4/6.
CDK4/6.
So I think that's where we're at right now.
Yeah, and it's rather unfortunate if after CDK4/6 they recur again after a year. I mean, that would be something. But yes, you do have that population of patients which we'll be addressing. We're not as lucky to have. So Bonaki, we've been implementing, I think, for the last year or two, and its ribo has not yet been approved in the early setting yet. So I think we are waiting on that approval, which will come soon. And then I think things will get a lot more complicated. So next slide, please. So basically, this was very straightforward a few years ago, where you had these patients and, they metastasized, they were on AIs, and then you looked at the endocrine sensitivity, and you kind of put them on a CDK4/6 inhibitor and waited for things to progress. Can you keep clicking, please? Yeah, so upfront PIK3 testing, triplet therapy, second line imlunestrant that we talked about with the study with abemaciclib, both in ESR1 and PIK3 mutations. Please click some more. Yes, so genomic testing, which was earlier restricted to the second line, has moved up into the first line. And things are a lot more complicated than this diagram. Shaina showed a very nice one, which confused me even more, but never mind. Next slide, please. So who's our doctor from Tata? I'm sorry.
Anbarasan here, ma'am. Anbarasan Shekhar.
Can I call you Dr. Shekhar, please? That's simpler for me.
Yes, ma'am.
So Dr. Shekhar, Emerald-like strategy, waiting for CDK, considering elacestrant is available for CDK4/6 progression, or preemptive monitoring of ESR1. What would you prefer if both were easily available, accessible, affordable?
Ma'am, preemptive monitoring, I find it will be little difficult in our scenario, because doing every 3 months and getting those things to be done little bit difficult in our scenario, and to explain them. And also when we see the Serena-6 study, almost only 3,000 patient has been screened to randomize 350 population. That is only 10% of population has been screened, has been enrolled into the study design. So what happened to the rest of the patient? That is one of my concern. Second concern, even though they shown PFS2 advantage is there, but the percentage of population who are taken chemotherapy in the control arm is less compared to the patient who are taken in the study arm. So that is almost 10%. Probably that might also contributed to the PFS2 advantage in the Serena-6 study. So without getting a worse advantage, I'm little bit hesitant to practice preemptive ESR1 mutation screening in this population. We already facing the trouble of doing PET scan when the patient is asymptomatic, and we do a PET scan, there will be some amount of increased metabolism in the PET scan is seen. Otherwise, patient is asymptomatic. what happens if you do ESR1 mutation, whether you want to intervene or not to intervene? That will complicate our scenario.
So I think doc is reluctant because of the feasibility of the fact that it's very, very selective, the population. There is no OS benefit as yet. What do my other panelists say? Chirag, any comments?
Yes,
China?
I already said that I will very much want to look at the OS advantage before changing my practice, because using the drug a little later, oral SERD with maybe CDK4/6 inhibitor on radiological progression, whether that has inferior survival as compared to using it upfront, that is something which is more important for me.
China? Serena 6 or Emerald?
So, Serena 6, obviously, even Emerald, I think even the investigators of Emerald will tell you that in 2025, and it's not because Serena 6 is, the molecular progression versus radiological progression. I think the question that you should be asking is Emerald, Amber 3, or Serena 6. And for me, Amber 3 and Serena 6 are in one bucket and Emerald is in the other bucket, because in 2025, nobody should be giving single agent endocrine therapy. It should be combination endocrine therapy. And even elacestrant is going, their trials are undergoing right now. They're just looking at the efficacy of combination, because what Amber told us, what Serena 6 told us, is that you can give a CDK4/6 inhibitor beyond progression, and it works very well. So please give it. And if you have another target, you will also use a combination of endocrine therapy plus a target. So I think in 2025, it's very hard for me to envision a patient that I'm not going to give combination unless my hands were tied.
Okay, all right.
Ma'am, I would like to add it further. Because this newer studies are coming up in a rapid fashion. Recently, the Victoria study has passed on the press release. They are showing the median PFS advantage of 9.6 versus 2.4 months. Almost 5 months of PFS advantage is there with the newer drug called as getolisib. It is in a Victoria 1 study. So there are so many potential molecules that are coming up with respect to SERD and SERMs. So we can actually wait rather than implementing in an earlier fashion. This press release for Victoria study happened today.
All right. So you were doing some reading today before the seminar. That's
Yes,
great.
ma'am. And the hazard ratio is also 0.24 for the
No,
study.
I agree. We're going to have so many choices with different scenarios, and we're just going to have to put our patients into different buckets according to the clinical situation. So next slide, please. I think we've seen this. We'll just, Serena 2 has been extensively discussed, so has Emerald. Let's go on, just keep clicking. Let's go to the questions. Okay. So what's your bet, Shaina? Do you think we'll see an OS benefit with this approach?
I don't think Serena 6 is going to show an overall survival benefit, and I could be proven completely wrong, but will that deter me from actually doing Serena 6 in my clinic? Absolutely not. For me, in a patient that's ER+HR positive, HER2 negative, having such a huge progression-free survival benefit, even if I do sequential, I might get a better benefit, but I'm losing in that drop. And that's where Serena 6 actually tells you that exactly you're overcoming that group of patients that drops off very quickly. And you and I have both seen this in the clinic. When you give patients CDK4/6 plus AI for a long time and they start progressing, they progress really badly. And whatever you throw at them, they don't do well.
They do very badly.
Exactly. So I like the early separation, the Kaplan-Meier curves.
And if
like
you
the
look
PFS
at all this, if you look at all the curves of CDK4/6, all have that drop. I mean, you can literally draw that curve through memory now. So, you know, we've been fighting to reduce that sudden drop that we've been getting. So, yeah, I think this is encouraging. Next slide, please. Yeah, we've covered this as well. When is the right time to test? So, as you test, you will find more and more positives. The right time is probably 6 months when they start emerging, and 6 to 30 months is what we really discussed. So keep going. Next slide. Yes. So this is what we found. Now, Chirag, you practice here. So how adaptable is this repeated testing every 2 to 3 months for ESR1? Okay, let's say it's reasonable, it's easy to do. The labs that we're going to talk to do them regularly. It's well validated and they're giving you a special rate for your patient. Would you do it every 3 months?
So, Dr. Shaheen showed in one of her slides that the median time between molecular progression and the radiological progression is about 5 to 6 months.
Right.
I believe 2 months is little too early. We should be testing every 3 to 4 months, and that makes sense to me.
Okay. Dr. Shekhar, I think you have disagreed with a lot from the start. So let's see what you have to say. If
Ma'am,
ATTRACT was doing it as a free study, ESR1 mutation testing for all metastatic ER positive patients, and you were to put your patients on this study, how would you design it and how often would you test your patient?
once in a 6 months will be doable, or once in 3 months also it is doable. If it is free of cost, then we can consider. But ultimately, we have to answer the patient when the test become positive, what we are going to do. Unless drug is freely available, doing this test will not carry any meaningful effect. Ma'am. I also have one concern. Here,
Yes.
that first positive test rate is 51%, but still the median rate for median time duration is 22 months. For ESR1 mutation, those population detected around 22 months. Why the difference is there? That I want to, that point I was a little bit confused, because most of the patient on first stage itself positive. But when we see the median time duration in terms of months, it is 22 months. Why the difference is there? If
Can I,
anyone able to,
can I answer that? Can I answer that if
Yes,
that's
of
okay?
course, it's for you.
yes.
Oh, really? Oh my God. Okay. So you have to go back to that box that I had shown you of the characteristics. And I think I pointed it out I think in the design of the study right from the very beginning, that the majority of these patients had been on a CDK4/6 inhibitor for more than 18 months. So you would expect that 50% of these patients are going to have an ESR1 mutation at that time. So it's the median is 22 months. So you see where I'm getting at. I'm just looking at the data. 62% of patients were on a CDK4/6 inhibitor for more than 18 months. So it makes sense that median of 22 months makes sense.
And how long would you continue monitoring for these mutations? You already covered it, up to 3 years?
So
or
if you look
longer?
at PADA, for me, it's between 6 to 30 months. After that, the probability, and you can even see that in SERENA-6 as they
The bell
continue to
curve
test.
that you showed.
Exactly.
Yes.
So
Yeah.
the highest number I would do infrequently would be between 6 and 30 months. I would not do it before 6 months unless, there were other factors involved. After 30 months, I mean, I have a patient right now, 7 years on a CDK4/6. I'm not going to keep testing for an ESR1 mutation in this patient all the time. That it doesn't make sense.
Yeah.
It's between 6 and 30 months that you get your highest group of patients that will be ESR1 mutation positive.
Great. Next slide, please.
I have also one more question, ma'am.
Yes.
Here in SERENA-6, what they done is 60 to 70% of patients were on palbociclib. Whereas in our current practice, if the patient is affordable, we mostly put them on other two CDK4/6 inhibitors. So how we can take this into the real world practice? Because in India, I can agree that still 80 to 90% of patient is on palbociclib. But in majority of other countries, it would be other way. So how we can take that into the practice?
I think that if like in my practice, I use a lot of abemaciclib. It's not going to make a difference. If anything, I'm probably going to see a better difference in the progression-free survival of these patients, because we know the differences between the different CDK4/6. What's cool about SERENA-6 is that it didn't alter the CDK4/6 backbone. It continued the same CDK4/6 that the patient was on and just continued it in two arms, telling us fundamental question is the camizestrant that's driving that difference, not the CDK4/6 inhibitor. I think the real question you should be asking me is that if I switched You guys in India are using 90% of your patients on palbociclib. If you switched from palbo to say abema or ribo in combination with camizestrant, which is not what you should do because that's Serena-6 didn't do that. But if we switched, would we get an even better difference?
Yeah.
We don't know. And that those questions are being asked in clinical trials right now. But for the time being, it gives me comfort that this is
It might
working.
be interesting because ribo and abema have shown the OS benefit. And, you know, if you combine one of those two with camizestrant, you may get a better result. Who knows? So,
But I would also like to point out that in Serena 6, even though subgroup analysis is not powered, but when they used Abima with the arm which contained abemaciclib, it has crossed the median of unity. So it is
It's
not
too
showing any
small.
difference.
The numbers are
It's too
very
too
small,
small.
I
small.
You
agree.
cannot draw any conclusions from it. It's way too small. I saw those numbers. You have 580 patients, of whom 70%, more than 70% received
taken
palbociclib.
palbo.
There's no way you can make those conclusions with either Bema or ribociclib. You would need real world data to be able to make those conclusions. But what we do know is from post-monarch and maintain that when you switch
Correct.
to CDK4/6, it makes a difference.
Yes.
What we don't know is that if we combine it with an oral SERD, whether that will make a difference or not. My point with Serena-6, it's telling us the value of camizestrant. It's telling us with that same CDK4/6 inhibitor, camizestrant is doing better than an aromatase inhibitor in the presence of an ESR1 mutation. And Serena-2 already told you that camizestrant is better than fulvestrant. So if you extrapolate, this is actually brilliant results that we're seeing right now.
Yeah, and maintain, you had to change both. You had to move from palbo to ribo, and then you had to change your endocrine arm also to get some kind of benefit. So, yeah, taken in. So let's talk to our molecular biologists. Moshmi, we'll start with you and then go to Suruchi. Considering that the test requires serial monitoring, do you see any practical issues such as right now, such as cost, inconvenience, which would limit the testing that you do in your lab?
Yeah, first of all, thank you. And I also thank myself for not choosing a clinical branch because I can see the level of confusion it is there and it is going to increase from here only. So yes, for now, ESR testing can easily be done by digital PCR if you're just looking at ESR1 testing. But how I am seeing it, because I have been hearing wonderful presentation by Dr. Shahina, and I think it will not be only ESR1 mutation testing eventually. It will be, we'll need to check everything because there could be a HER2 mutation also, not only your big three CA or other mutations. So, but if you just ask me about ESR1 testing, I think we are already very comfortable with ddPCR. Most of the labs have them. So it should not be a problem. It is more of a problem from your side that you have to advise the patient to be tested after 2 months or 3 months. From
So
me, that's
you
not a
have the
problem.
easy job. That's what you're saying, Moshmi.
Yes,
Okay,
it's
let's
just
go to Suruchi. Suruchi, how often do you get a requisition for ESR1 testing? I'm not talking of serial testing. How often do you get a requisition for ESR1 testing?
Thank you. Thank you for the opportunity, ma'am. So we do get, so right now, I think from last 6 to 8 months, we have started getting the prescriptions for ESR1 testing. And not only ESR1, we do get the request for ESR1, AKT1, P10, PIK3CA, ERBB2 in combination. And that too in the advanced breast cancer, as we are talking about, on the
Yes.
liquid biopsy platform, because tissue
Yes.
is inaccessible. However,
Right.
as I could see, like, the requests are mostly focused. They don't want the entire short liquid biopsy panel or a long liquid biopsy panel. I mean, the broad liquid biopsy panel. At that point of time, they would like to focus on either only on ESR1 mutation or just go by these 4-5 genes at that point of time. So as a lab, to have that shorter panel in the less cost on next generation sequencing is a little bit challenging. And that's what your first question, that yes, of course, the cost is one issue.
Sure.
But as Dr. Maushami suggested, that ddPCR alone for ESR1 could be helpful. And if we are just looking at the hotspots, I think the amplicon-based panels would reduce the cost a lot.
Okay. Okay. So can we go to the next slide and have Dr. Trupti on board? Okay,
Also,
we won't.
yeah, sorry. Coming to the prior question, like we are talking about serial monitoring, but what in like real life scenarios, what I see is hardly any request for molecular testing we get, especially NGS. Very rarely I remember instances where we get for PIK3CA in the similar metastatic scenario of hormone positive, and very, very rarely for ESR1. So Dr. Anbarsan is here. He only calls me for very rare cases. So it is not a very usual trend to get molecular testing in breast. That is what is the thing.
And
Another thing,
Dr.
the
Anbarsan, excuse me, 1 minute, 1 minute, 1 minute. So point taken that molecular testing in breast is not routinely recommended. Dr. Anbarsan, is that because you have no drugs available? And is that why, because a lot of these mutations have great prognostic value as well. They tell you about the disease, they tell you about resistance mechanisms. So why is it that we are not doing more panels, you think, in breast, especially ER positive breast?
Yes, ma'am. Actually, the cost of the drug is on the higher side, ma'am. Even fulvestrant, we got access around 6-7 months before when they include
Okay.
in the Ayushman panel, because
Okay.
even more than 5,000 drug is costly for a majority of our patient. That is
All
the
right.
reason we not suggested for ESR1 testing
For
largely in
ESR.
our population, ma'am.
All right. Okay. Trupti, please
yes, another
continue.
thing, yeah,
Can
another
I
thing.
just add something here? Like from my experience, what I'm seeing is that in breast cancer, though we have a different kind of patients in our hospital from Ayushman to the international clientele also. So what we are seeing is slightly different. We are actually seeing increase in the comprehensive genomic profiling for hormone positive breast cancer. So, and germline testing for BRCA1, BRCA2 is also increasing. There is far more awareness, but even the comprehensive CGP is also there. In fact, the patients who are very infoding, there is a baseline liquid biopsy also which is being added. So it is, I think, money is a big concern in our country, but there is different strata which are asking for different things. But yes, if it is not a concern, then I think most of us will like to have it.
Okay. Can we talk to Dr. Rekha Pai, please?
Hi. I'm around.
Hi, Rekha.
Yeah.
So this is a question that has been put up that, when we treat lung cancer, and unfortunately I don't, it's often seen that if you do a liquid biopsy very quickly after treatment, you will get a false low ctDNA, and especially when you're looking for actionable mutations. So when you're testing for ESR1 in the clinic, would you like a gap after therapy, and how would you even do that? Because if you're giving a hormone therapy and a CDK4/6, you're giving it every day. So, would you require a gap to actually detect an ESR1 mutation?
I was actually trying to look up what sort of data is available for this. I think the data particularly is iffy. There's no clarity as such. But presuming the way things are with lung, I think it would be best to not go in immediately for a liquid biopsy, to pace it gradually, and then go into a monitoring format with a longitudinal follow-up if possible.
Shaina and
But I
Chirag,
think
It's different.
sorry,
Lung. Sorry, go
can I
ahead.
just add in? At this point, I think we need to bring in the fact that there are a lot of pre-analytical considerations when we're working with liquid biopsies. And I'm very sure all my panelists who are from the lab will agree that we first need to sort that out and be very clear about our testing formats. It's not just about ddPCR, it's not just about going with the NGS. It's about how you've sorted out the collection of the sample, transport to the laboratory, because there are a lot of considerations when you're working with liquid biopsies. So I think all that needs to be factored in when we talk about, when is the best time to collect it? How should it be transported to the laboratory? How should the laboratory really work the logistics out and work out their quality control, and then put out their data.
So breast cancer is very, very different from lung cancer. So I don't think we can equate the two. In breast cancer, we've seen this from PADA and we've seen it from Serena-6. You're on medication and you develop a resistance to the medication. That's how these resistant mutations actually come, and that is the ESR1 mutation. So you don't have to do any sort of gap in your therapy. You just test for it. What you do see differences is the VAF. And then you can see the VAFs go up and down based on whether you're on therapy or not. But that doesn't make a difference to us in the if I have a patient with a PIK3CA mutation and ESR1 mutation, what will I choose? Likely not based on VAF, likely based on the fact that I look at the whole natural history. If a patient has been on a CDK4/6 inhibitor for less than 6 months, I'm definitely not using elacestrant in that patient. I'm going to target the PIK3CA irrespective of the VAF. So it depends on so many different things. And I'd like to go back to Serena-6, and I hope AZ is there that can chime in because they obviously have more information than I do. It wasn't about the VAF. It wasn't about, which mutations were there or not. It was a binary. Do you have an ESR1 mutation or not?
Yes or no.
Randomize you, right? It's not like PADA where they looked at the rising VAF, which was, again, we're going to see a lot of data come out from PADA, which allowed, for us to be able to understand those ESR1 mutations a lot more. I did in my presentation, if you remember, I presented the two cases that sort of came to my head. What are we going to do if you have a patient that you're testing and you're seeing a rising VAF of your PIK3CA mutation? That's a patient that's blowing through the treatment that you're getting as well. What are you going to do with that sort of a patient? Are you not going to intervene? Are you going to say, look, I'm going to wait for radiological progression so that I lose you completely to chemotherapy? No. I think the complexity of what's going to happen.
Absolutely. And I think the future is imminent, and it's going to come sooner than later. And we're going to have to go by these markers earlier on than later. Definitely, we want results. So let's go to the next slide.
Can I just intervene here about this?
Yeah.
So all the things about targeted, but whenever there is a chemotherapy that is being given, at least a gap of 1 to 2 weeks is done whenever we are doing liquid biopsy.
Sure.
So irrespective of whether a breast or lung, that thing is for chemotherapy.
See, that's understandable, but these patients are never on chemo. These patients are on,
Another thing, like even if we are not measuring VAF, but even to call something as positive on liquid biopsy, every lab will have a different cutoff. So like in this trial, they had used Garden 360, but actually when in practice, which lab you are sending and what is their platform depth, everything will matter. So maybe some people are just taking a cutoff of 0.3% or 0.5%, and some can go down to 0.1. So even to call something as mutation, we'll have to look at VAF, no matter if we are reporting or not, but that will matter. So if your pre-analytical things are not taken care of, there will be dilution of VAF. So sometimes positive can also come as negative.
Honestly, I think that's where the dialogue starts between the clinicians and the molecular biologists. And we have so many patients in India who are on CDK4/6 inhibitors, who are on AIs in the metastatic setting. It's up to us to really collect this real world data, and maybe AZ can step in, and the two sets of people can collaborate and really look at the percentage of ESR. It's not going to be any different, but at least we'll have our data, and you can do the pre-analytical stuff as well as you need to be ready for prime time. So that's just a comment I had. And I think it's been mentioned by one of our biologists that digital droplet PCR is the way to go. Do all my panelists agree?
So I think when we do the NGS, we pick up multiple mutations, and
try
to go in future. We just don't want to look at ESR1 only. We want to look at PIK3CA. We want to look at ERB2, and maybe sometime down the line we will start looking at other mutations as well. So even though ddPCR is slightly more sensitive for ESR1 mutation, I will want to do with NGS.
So for ESR1 specifically, ddPCR is good, but otherwise a broader NGS to give you more information about other mutations is recommended. Okay. Next slide.
I think we need to just factor in that the cost is also much lesser when we go with the ddPCR. Your
Correct.
cost is lesser, your turnaround times are far sharper and better. So there are some advantages to going with ddPCR, but agreed, the reference range being so low, it would certainly be better to go with an NGS if you want to look at, the entire spectrum of mutations that may be.
Okay, so there were a few questions in our chat box, and we've already addressed that ESR1 mutations are better detected on a liquid biopsy than tissue. The second question was, how can ESR1 mutations be used to personalize treatment for ER-positive patients? I think we've discussed that as well. We've talked about camizestrant, we've talked about elacestrant. Shaina, how do ESR1 mutations impact the development of metastasis per se? That's one of the questions.
So it's not the ESR1 mutation that's impacting the development of the mutation. It's you're treating a patient with a certain agent, that endocrine therapy becomes resistant through the ESR1 mutation. And because it's become resistant, that medication is no longer effective. And that's how metastatic lesions progress. I think the question that he's probably trying to ask, or whoever's trying to ask this question, is what about in the early stage setting and recurrence of disease? And I think that's a very valid question in the recurrence setting, because we're now treating all our patients with AI and CDK4/6 inhibitor in the adjuvant setting. We're going to see more and more of these patients develop an ESR1 mutation at some point in time. We don't know how CDK4/6 in the adjuvant is actually going to play out with that point, but it can potentially be a mechanism by which, once you've completed your CDK4/6, you continue on an AI, you're developing resistance because of the emergence of an ESR1, and that's how a metastatic lesion actually develops. So it's possible.
Okay. And Chirag, there's a question. What are the implications for adjuvant therapy, if any, of ESR1 mutations? So along the same line as to what Shaina said, but your thoughts, please.
Well, to that extent, a number of trials are going on. Some trials are enrolling the patient early in the adjuvant setting, and some trials are enrolling the patient after 2 to 5 years of standard adjuvant hormonal therapy is completed. And all these trials are looking at the translational aspect as well, whether ESR1 mutation is developing or not, whether that has any implication on the outcome of these patients or not. So at present, we don't have a good answer. We only can guess. But if someone is asking me that what sort of design is best for this situation, I will want to use oral SERD after several years of the standard adjuvant hormonal therapy, because that's the time when there are maximum chance of developing ESR1 mutation. And as Dr. Shaina said, between 2 and 3 years is the optimum time, not early, not late.
True. And a lot of the SERDs have been tested in patients 2-3 years post AI in the adjuvant setting as well. Another question, how does Serena-6 phase 3 use a ctDNA guided approach to detect emergent ESR1 mutations? So anyone from the lab want to take that? Rekha?
I think it was done at 6 months, and then every 3 months, 2 to 3 months, they continued doing. And as indicated today, the first test, that is the 6 months, at that point in time, 51% of them were positive. They went with a shorter panel, which is a 55 gene, roughly a 55 gene
Right.
panel with Gordon. And I guess, the rest of the data is there to see, yeah.
Shaina, are all ESR1 mutations created equal?
No, the simple answer is no. In fact, there was a very nice study that was presented at San Antonio as an oral presentation and then subsequently published, that actually showed, based on the plasma match trial, where they actually looked at the efficacy of fulvestrant based on the type of ESR1 mutation. There's some ESR1 mutation fulvestrant will not work, and there's some ESR1 mutations that it'll work very, very well. Whether we're going to see the same with oral SERDs is something that we're waiting to see that data. But I suspect we're going to see a similar thing where you're going to see differential efficacies based not only on the number of ESR1 mutation, I showed you that from the SERENA-2 trial, but also on the type of ESR1 mutation that you're going to see. But what I think SERENA-2 told me, and I think this was the basis also for SERENA-6, the earlier you treat, the better the efficacy of the oral SERD. So you don't wait for multiple mutations to develop, which is what's going to happen eventually.
So you're actually preventing mutations from developing with this early strategy. Next slide. Next, yes. So we did refer, and Shaina did refer to co-occurring mutations in her talk. And that's going to complicate things even further, where you're going to get ESR1 along with PIK3 alterations. And they may not just be a PIK3 mutation. There may be alterations down the PIK3 pathway. And then you're going to have to deal with targeting one or targeting both. So Chirag and Dr. Shekhar, after that, are we going to combine these treatments? If we have a BRCA again in the picture, are we going to combine a PARP1 with these? What is your take?
So we have some data from imlunestrant trial that co-mutation with PIK3CA and ESR, imlunestrant with abemaciclib has the better outcome as compared to the other options. And I can extrapolate the same for AKT1 and PTEN mutations, but we are not sure about BRCA mutation. If there is BRCA mutation, if at all we have to initiate a trial, we will not combine olaparib with CDK4/6 inhibitor with an oral SERD because the likelihood of neutropenia will be much higher with that combination. So for BRCA1 and 2 co-mutation, I don't think I will change my treatment right now. I'll be giving single agent olaparib at some point in time. But otherwise, with other mutations like PIK3CA, AKT1 or PTEN, I'll be using the imlunestrant approach, AMBER-3 approach.
AMBER-3 approach. Dr. Shekhar, any thoughts on targeting these co-occurring mutations?
If it is BRCA with any other thing, I preferably use BRCA inhibitor in second line because combining these two will be more toxic. Even in SERENA-6, the rate of hematological toxicity is very high. So I don't think combining these two will be a feasible option. And I also look into the other options also. When there is a co-mutation, it is proven that the patient will have poor prognosis with co-mutation. So based on the clinical scenario and status of the patient, TDXD also comes into the picture in this scenario. So I also keep the option of going for chemotherapy or using a target therapy like TDXD in this scenario, apart from this targeted therapy.
So Dr. Suruchi has put up a question saying if you have co-occurring ESR1 and PIK3 mutations with a high TMB, what would you do? Shaina? How sold are you on TMB in breast cancer?
So it really depends how high that TMB is, because the cutoff of
if it is 100 and above, like we just discussed this case in one tumor board where there were like multiple mutations in ESR1 gene and with stratified VAF, and then multiple mutations in PIK3CA 542, 1047 and whatnot, and then TMB was as high as 130. So,
and what was the most recent treatment the patient had?
I think the patient was on hormone therapy and CDK4, CDK6 inhibitors. So
okay, so AI CDK4/6 probably, and then develops this kind of
and
profile.
Essentially, for
almost 15 to 20. Sorry, yeah.
Go ahead. No, go
almost
ahead.
15 to 20 mutations on the report.
So essentially, this patient has a genomically unstable tumor, most likely has an ApoBac signature. If you go back, I would request you to check that. With such a high TMB, all the mutations that you're seeing is because it is a genomically unstable. And I would go back and see this patient has a pol E mutation or not, either APOBAC or a pol E. Irrespective, this patient needs immunotherapy. I would give not one,
Poli was
but two
VUS.
immunotherapies, and it works because we have data. We
Poli
actually
was
have data for
VUS.
that.
Yeah, Poli was VUS, ma'am.
So I would go back
Oh
to
God.
whoever's reported it and see whether really if it is a VOS or not. But I would look at the APOBAC as well. If the TMB is being read by a lab that you trust, because it actually has to be a good lab as well, and you're seeing such a genomically unstable tumor, you have data in breast cancer where you look at giving Nivo and Ipi in these patients with such a high TMB and in hormone
It
receptor
works.
positive, and it works.
Yes,
It works very
it
well.
would. It
However,
would.
I have to admit, if I were to do that, I wouldn't do it alone. I'd probably add some chemotherapy to it because you can't predict these unstable tumors as well. But I would definitely give dual immunotherapy to someone whose TMB is 150 with such a genomically unstable tumor.
Sure, ma'am.
Thought as much. I said, how can Shaina be happy with IO alone? She's not going to give IO alone.
No,
She's
no.
going to add something to it.
I will add something to it.
All right. So I think we've had a great discussion and I think time's up. So thank you, Shaina, for a brilliant talk. Thank you, Chirag, for your insights. Thank you, Dr. Shekhar. Thank you to all my wonderful molecular biologists for your contributions. And thank you, AZ, for hosting such a thought-provoking webinar. So good night, everyone, and thank you for your attention.
Thank
Good night,
you.
ma'am.
Thank you.
Thank you so
Thank you.
much, ma'am,
Bye.
sir.
Bye.
Thank you.